Here's a big question for the exchange. In now 2014, Uncle Sam is paying for the development and operation of the exchange. 2015, the state of Minnesota has to figure out how to pay for the exchange. So how do you sustain the exchange? In the bill, the exchange is given the ability to levy up to 3.5% of the premium in order to pay for its operation. Now, when I say that, that's not a surcharge on top of the premium. That's a withhold from the premium charge. Because the products in the exchange have to be the same price whether they're sold in the exchange or not. The same exact product has to be the same price. The exchange potentially could also do things like sell naming rights in advertising, but that seems like probably the least likely option at this point. This one is more inside baseball, but it is an area that has been generating a lot of discussion and question. And this is actually an area where physicians may have a role to play. How do we connect people with the exchange? Yeah, it's intended to be an online marketplace, but even in Minnesota, broadband adoption is somewhere around 60%. Not everyone has access to the web. So they're going to need to be, and I apologize for using the jargon, boots on the ground in terms of connecting people with this new marketplace. People introducing them to not only how do you use this marketplace, but for some of the populations we're targeting, the concept of insurance, period. So there's an assumption there are going to have to be folks who serve the role of navigating the process, which is why an exchange has to develop a navigator program. Folks who tell folks how do you use the exchange, what do these products mean, have to be culturally literate, competent. So that's one range of folks. Now, there are some folks currently who would raise their hand and say, wait a minute, we do that already. They're called agents and brokers. What skin or what place do they play in the exchange? Well, the exchange bill contemplates the use of agents and brokers as a way, not the exclusive way, but as a way to connect people to the exchange. The bill goes on to also say, and the exchange shall determine the compensation levels for those folks working on behalf of the exchange. The brokers don't want to be paid by the exchange, oddly enough. And I've never, and they are my friends, I've never been able to understand why, if they're doing work on behalf of the exchange, they shouldn't be compensated by the people they're doing work on behalf. They would prefer to be paid to continue as they are today, paid by the plans. Now, our take on that is then you kind of expose yourself to potential conflicts of interest. Are you giving advice to consumers based on your relationship with the plans, or are you giving advice to consumers based on the fact that you really should be trying to put them in the plan that is the best quality and value for that consumer? Now, they would get really annoyed with me at saying that because they say that's exactly what we do. We would then respond, can you tell I'm rehashing a debate that's occurred a few times? If that's true, why not just have it be transparent? Why create any indicia that somehow your advice is somehow influenced by some fiscal relationship you have with the plans? So, big topic that is likely going to be the subject of many a committee discussion. Oh, and when I say that, we're expecting to go through at least 15 committees. To give you a sense of what kind of bills typically go through 15 committees, stadium bills go through 15 committees. Typical bills go through it, if we're lucky, 4. So I get to sit in those committee hearings. So there you go. And the last question around the sort of policy issue for an exchange that's going to be resolved, and it's not in the exchange bill, it's more going to be resolved in other vehicles, is how do you make sure the exchange doesn't suffer from that phenomenon known as adverse selection? Adverse selection is the annoying tendency of people to do what's in their economic self-interest. Remember, we're moving to an environment in 2014 where it's guaranteed issue. People get to buy insurance without any sort of medical assessment. In an environment where that occurs, you have a potential moral hazard where people wait till they actually need insurance to buy it. Well, what does it mean? Well, it means the cost of insurance goes up. That's probably not a good thing for an act known as the Affordable Care Act. So one of the things we have to figure out is how do you set up market rules so folks don't engage in practices where they game the system and get coverage, when they know they are going to need it. What are the impacts of the exchange for practitioners? Public health impacts. Well, the fairly obvious one is a reduction in the uninsured rate. We're around 9.1% uninsured right now. By national standards, that's pretty good. By Minnesota standards, that's pretty bad. That's an increase from our normal national leading numbers. The exchange has the ability, with the subsidies, with the clarity and ease of enrollment that it hopefully will provide, of lowering that uninsured population by 65%. The exchange also has the ability to be tied to such efforts like healthcare homes, like care integration that Doug's going to talk about. You can align, so when we talk about incentives, one of the most powerful incentives, at least my former colleague, April Todd Mamela, the executive director of Exchange, would point out, are economic ones. An exchange is an interesting place to align the fiscal impact of payment and co-pays with healthcare initiatives. So it's a potential tool for being connected with our reform initiatives. For physicians, for participants in the healthcare process, the exchange has implications for outreach and education. You, as discussed, are a trusted source of information to your patients. You don't be surprised if some of them ask you, what is this marketplace I hear about? And by the way, it won't be called the Minnesota Insurance Marketplace. It will have some cool, snazzy name, I hope. That'll be catchy. To give you a sense of the sort of other names floating out there, at one time, California was thinking about calling their exchange Avocado, which I kind of liked. But my single most favorite name for an exchange is, assuming Mississippi can pull this off, because there's a tension between their insurance commissioner and the governor about whether they should run one. They're calling their exchange One Mississippi. So I'll let you, yeah, well, this is a smart group. They didn't take that long to figure out. Other issues you guys want to think about is the exchange has the potential to develop something called a basic health plan. For those of you familiar with the product known as Minnesota Care, the basic health plan could be a replacement for Minnesota Care. It provides a level of coverage, benefits, and cost supports that are greater than would be required under the minimum requirements under the product sold in the exchange. So one of the big policy decisions, potential public health impacts for you folks are we going to implement a basic health plan? I will tell you the administration is working very strongly to try to be able to get the flexibility, guidance, and just as importantly, the money to do a basic health plan. Our friends at CMS sagely stroke their chin and go, good concept, interesting, but they've not given us the high sign yet, so we continue to advocate on that item. Lastly, the area, and this is actually broader than this exchange because it applies inside and outside, you folks are going to want to be engaged in the discussion around what should the product include in the way of benefits. And there's a concept or a structure known as the Essential Health Benefit Package that are sort of the core minimum requirements that every plan going forward need to include. There are roughly 10 categories, and I will apologize, I don't remember what the 10 categories are, but if you want to think about them by analogy, and being a former English major, I tend to think that way. It's like being told as a restaurant, you have a menu, you need to create a menu that has food in the following courses: a salad, a soup, a meat, a bread. They tell you you can't exceed so many calories in any one course, but other than that, you have the ability as a plan to figure out how to meet those requirements. Why is that material to you? I think you're going to be engaged in a dialogue around services, coverages, benefits, to be sure that those align with the fundamental objective of making sure that the folks that get this end up healthy, right? That's kind of the goal of why we're doing all of this. So those are the policy issues that are being discussed. That is the role you may play or how the exchange may impact you. If you want to weigh in, the next time to do so is at the House Commerce hearing on Tuesday night. I'll see you there if you do.
Thank you, Manny. All of the products that are now available through the health plans and insurance companies, will those be the very same products that are on the healthcare exchange? Or will they have to go through some way of qualifying those products to be put on the exchange?
So my department, the Department of Health and the Department of Commerce, are the functional FDA to this new supermarket. We have to bless that the products that the exchange sell meet certain standards. Some of those standards are existing ones that a number of the players in the marketplace already know. For example, there's a network adequacy standard. People in Minnesota who write in HMOs have to meet that standard today. That's the same standard we're going to apply to those products. So that in that respect, and by the way, the short answer is sorta, kinda.
Sorta.
Some of the standards are standards that the plans know today. Mm-hmm. Some of the standards are brand new ones. So EHB is a new standard. Having said that, the EHB benchmark in our state is a Health Partners plan. So I'm guessing Health Partners will meet that standard pretty easily. Mm. There's another standard that applies to both products inside and out of exchange. They actually need to provide value to consumers. Interesting concept. That means they have to provide to be sure they pay for a minimum of 60% of projected claims costs. Okay? And I want to underline projected because this is an actual concept. They have to have a minimum actual value. They have to meet certain marketing standards. Again, that's an existing standard that applies today. And then lastly, they have to meet a standard yet to be fully fleshed out, not this year, but in subsequent years around quality. Oh, that's probably another place you guys may want to weigh in on. Mm-hmm. Is what does it mean to be a quality health plan? Because I suspect that it's going to be a blend of both access to the care provided and the nature of the processes by which they deliver the financing mechanism to get to you guys.
Thank you. Panelists, do you have any questions for Manny? Yes, Ann.
Manny, you mentioned that about 20% of Minnesotans are going to be accessing their insurance coverage through the exchange, and I've heard estimates nationwide that the number is more like 4 or 5% of Americans overall are going to be using the exchange. So that obviously implies that Minnesota is doing it quite differently. Is the main difference that we're rolling in Medicaid? And if so, do you know if we're the only state doing that, or are there other states?
So two-part question, and the short answer is yes, it's Medicaid is the biggest driver as to why our exchange is more material than in other states. But there are other states that are moving along the same path to a more integrated structure. I would say Washington, Oregon, and Maryland are potentially in that category. I would put the District of Columbia in a category of its own. They are requiring their entire individual and small group market to go through the exchange. So their exchange becomes the exclusive market in town. The state of Vermont is an interesting, I don't know how to categorize it in your scenario, because they're using their exchange as a transition or bridge to single payer. So they're going to eventually use their exchange to be their enrollment platform for their entire state. Now at that point, the exchange doesn't become a marketplace per se, but really more of an administrative tool for enrollment. And you still need big IT pipes and data and analytics to be able to pull off enrollment.
Thank you.